And there are some panel regarding jaundice. The first is liver function test. The indications of liver function test: screen for liver disease, identify the nature of liver disease, assess severity and prognosis of liver disease, follow up the course of liver disease. Commonly performed liver function test: serum alanine aminotransferase, serum aspartic aminotransferase, serum alkaline phosphatase, serum bilirubin, serum albumin. How bilirubin is produced? First, destruction of red cell. So RBC destruction, heme, from heme, protoporphyrin, then biliverdin, then bilirubin. This process occurs in macrophage. Then in circulation, bilirubin-albumin complex. Then in hepatocyte, bilirubin to bilirubin diglucuronide. This is called conjugated bilirubin. This conjugation occurs in hepatocyte with the help of glucuronide transferase. Then this conjugated bilirubin come in the biliary canaliculi, bile duct and gallbladder. Then intestine. It is from urobilinogen. And some part of urobilinogen goes in the kidney and excretion in urine. This is the normal bilirubin metabolism. So, liver function test can be classified as test that assess excretory function of the liver, bilirubin in serum and urine, and urobilinogen in urine and feces, test that assess synthetic and metabolic functions of the liver, serum protein, serum albumin globulin ratio, and prothrombin time, and blood ammonia level. There are some tests that assess hepatic injury: serum alanine aminotransferase, ALT, serum aspartic aminotransferase, AST, serum alkaline phosphatase, it is called ALP, and serum gamma glutamyl transferase or GGT, and 5-nucleotidase, 5'NT, and test that assess clearance of exogenous substances by the liver, brome sulfatolene excretion test. Now serum bilirubin. There are two types of normal serum bilirubin is less than 1 milligram per dl, normal level. There are two types of bilirubin, unconjugated and conjugated. Normally conjugated bilirubin is 10% or less, and unconjugated bilirubin is 90% or more. So what is jaundice? Jaundice is the yellowish discoloration of skin and sclera and mucous membrane due to increased level of serum bilirubin. Jaundice becomes clinically evident when serum bilirubin level exceeds 2 milligram per dl. Now classification of jaundice. Predominantly unconjugated hyperbilirubinemia cause hemolysis, resorption of a large hematoma, ineffective erythropoiesis, Gilbert syndrome, physiology jaundice of newborn, and Crigler-Najjar syndrome. Predominantly conjugated hyperbilirubinemia cause hepatitis, cirrhosis, cholestasis, drugs, toxins, Johnson syndrome, Rotor syndrome, and mixed hyperbilirubinemia. Conjugated bilirubin is 20 to 50% of total. It results from viral or alcoholic hepatitis. Now, according to etiology, hemolytic jaundice, hepatocellular jaundice, and obstructive jaundice. Hemolytic jaundice, the increased rate of red cell destruction causes increased hemoglobin breakdown to bilirubin in RE cell or reticuloendothelial cell. This exceeds capacity of conjugation in liver. hepatocellular inability of hepatocyte to conjugate or excrete bilirubin. Obstructive failure of excretion of conjugated bilirubin into the intestine, causing its regurgitation in circulation. According to site of disease, pre-hepatic, hepatic, and post-hepatic. Pre-hepatic, there is excessive formation of bilirubin exceeding the capacity of the liver to conjugate it for excretion. The type of bilirubin increase in serum is of unconjugated type in pre-hepatic jaundice. Then hepatic, unconjugated and conjugated both are increased. Post-hepatic, this is also called obstructive jaundice, surgical jaundice, or extrahepatic cholestasis. So, these are the also pre-hepatic jaundice, hemolytic anemia, ineffective erythropoiesis, resorption of a large hematoma, hepatic jaundice, Gilbert-Krigler-Nassau syndrome, predominantly conjugated hyperbilirubinemia, viral hepatitis, toxic hepatitis, alcoholic hepatitis, active cirrhosis, and Dubin-Johnson syndrome. Post-hepatic carcinoma of head of pancreas, carcinoma of ampulla of Vater, secondary is in porta hepatis, gallstone in or stricture of common bronchitis. So, how we will differentiate by the liver function test and clinical signs and symptoms? Basic mechanism, pre-hepatic hemolysis, hepatocellular deficient uptake, conjugation or excretion by hepatocyte. In post-hepatic, deficient excretion due to obstruction in the biliary tract. Type of serum bilirubin, here it is unconjugated and hepatocellular, both conjugated and unconjugated type of bilirubin will increase in hepatocellular. In post-hepatic, mainly conjugated. Urine bilirubin, here it is absent, but in these two it will present. Urine urobilirubin increase in these two, here it is variable, here decrease. Prothom time normal in pre-hepatic jaundice, in hepatocellular, abnormal, that is not corrected with vitamin K injection. Post-hepatic, corrected with vitamin K injection. And there are some additional features of hemolysis and blood smear, like reticulocytosis, low haptoglobin, low hemoglobin. Hepatocellular jaundice, marked rise of serum ALT and AST. Post-hepatic jaundice, marked rise of serum ALP. So, clinical jaundice, serum bilirubin will increase, conjugated hyperbilirubinemia, predominant elevation of AST, ALT means it is hepatocellular injury, and predominant elevation of alkaline phosphatase means cholestatic injury or infiltrative disease. It will be normal in Dubin-Johnson and Locke syndrome. Unconjugated hyperbilirubinemia, evidence of hemolysis present, hemolytic anemia, ineffective erythropoiesis, absent, Gilbert syndrome, Krigler-Nassau syndrome. Severity of liver disease assessed by these three things. Serum bilirubin, number 1 is serum bilirubin, number 2 is serum albumin, and prothrombin time. Test which assess hepatic injury. Liver enzyme study, serum aspartic aminotransferase or AST or SGOT, ALT or SGPT, and ALP or serum alkaline phosphatase. Serum aminotransferase, most marked elevations of ALT and AST seen in acute viral hepatitis, toxin-induced hepatocellular damage, and centrilobular necrosis due to ischemia. Typical LFT profile in hepatocellular disease, marked elevation of AST and ALT, mild increase of ALP. It is occurring hepatocellular disease. In hepatocellular jaundice, marked elevation of AST and ALT, mild increase of ALP. Hyperbilirubinemia if present, both conjugated and unconjugated type in hepatocellular jaundice. Typical LFT profile in cholestatic jaundice. Marked elevation of ALP, elevation of GGT and 5' NT, mild or no increase of ALT and AST, elevation of conjugated bilirubin. So, by liver function test, we can differentiate between cholestatic jaundice or obstructive jaundice from hepatocellular jaundice. Just opposite picture, hepatocellular and cholestatic. Here, marked elevation of AST and ALT, mild increase of ALP. In cholestatic jaundice, marked elevation of ALP and mild or no increase of ALT and AST. So, non-hepatic cause of abnormal liver function test. Increased serum bilirubin, hemolysis, ineffective erythropoiesis, resorption of a large hematoma, increased aminotransferase seen in muscle injury, alcohol abuse, myocardial infarction, increased serum alkaline phosphatase, pregnancy, bone disease, low serum albumin, poor nutritional status, proteinuria, malabsorption, severe illness causing protein catabolism. So, these are the markers of hepatitis A. Anti-HAV IgM, anti-HAV IgG, anti-HAV IgM increasing acute or recent infection, anti-HAV IgG past infection or vaccination. These are the serological markers for hepatitis B. HBS antigen, anti-HBS, HBC antigen, anti-HBC IgM, anti-HBC IgG, HBE antigen, anti-HB and HBP DNA. Now the viral hepatitis serological panel. Causes of viral hepatitis: hepatitis A, B, C, D, E. Hepatitis A belongs to picornavirus group of enterovirus spread by fecal oral route. Investigation anti-HAV is important in diagnosis as HAV is only present in the blood transiently during the incubation period. Excretion in the stool occurs for only 7 to 14 days after onset of clinical illness. Anti-HAV IgM diagnostic of acute HAV infection. Anti-HAV G type is of no diagnostic value as HAV infection is common and this antibody persists for years after infection. It can be used as marker of previous HAV infection. Its presence indicates immunity to HAV. Now hepatitis C. This is caused by RNA flavivirus. Acute symptomatic infection with hepatitis C is rare. And there is virus hepatitis A, B, C, D, E. Among these, acute, which cause acute hepatitis A and E. Rest of have chronic course. Investigation. HCV contains several antigens that give rise to antibody in an infected person, and these are using diagnosis. It may take 6 to 12 weeks for antibodies to appear in the blood following acute infection. Hepatitis C RNA can be identified in the blood as early as 2 to 4 weeks after infection. Active infection is confirmed by the presence of serum hepatitis C RNA in anyone who is antibody positive. Anti-HCV antibody persists in serum even after viral clearance. Now hepatitis B, the most important cause of hepatitis. Hepatitis B virus consists of core containing DNA. It is DNA virus. Hepatitis B is one of the most common cause of chronic liver disease and hepatocellular carcinoma worldwide. May cause an acute viral hepatitis. Acute infection is often asymptomatic, particularly when acquired at birth. Investigations. HBV contains several antigens to which infected person can make immune response. These antigen and antibody are important in identifying HBV infection. Although the widespread availability of polymerase chain reaction or PCR technique to measure viral DNA levels in peripheral blood. Now first is hepatitis B surface antigen, HBS antigen, indicator of active infection. HBS appears in the blood late in the incubation period, but before the prodromal phase of acute type B hepatitis. It may be present for a few days only, disappearing even before jaundice has developed, but usually lasts for 3 to 4 weeks. Can persist for up to 5 months. The persistence of HBS antigen for longer than 6 months indicates chronic infection. Next is anti-HBS, antibody to HBS antigen. Antibody to HBS antigen usually appears after about 3 to 6 months and persists for many years or perhaps permanently. Implies either a previous infection, in which case anti-HBC is usually also present, or previous vaccination, in which case anti-HBC is not present. In a previous vaccination case, anti-HBC will not appear. Only anti-HBS will appear. Then hepatitis B core antigen or HBC antigen, not found in the blood, but antibody to it appears early in the illness and rapidly reaches a high titer. Subside gradually but then persists. Anti-HBC is initially of IgM type. After that it is IgG type. IgM means it is acute type. IgG means it is chronic type. Anti-HBC IgM can sometimes reveal an acute HBV infection when the HBS antigen has disappeared and before anti-HBS has developed. HBE antigen, indicator of viral replication, means the disease is active. HBE antigen reflects active replication of the virus in the liver. Natural history of chronic hepatitis B infection, first normal, then chronic hepatitis, from that minimal inflammation, then chronic hepatitis, cirrhosis, and hepatocellular carcinoma. Now the panel card. So, HBS antigen present for more than 6 months. HBE antigen present আর anti-HBC IgG present. তাহলে কি হবে? বলো, তোমরা বলো। কি হবে? ক্রনিক। শুধু ক্রনিক বলবে? হ্যাঁ? ইমিউনিটি কি করে তোমার? হ্যাঁ, কিন্তু তোমার তো ইমিউনিটি কি করে বলছি? HBE অ্যান্টিজেন প্রেজেন্ট। HBE অ্যান্টিজেনটা প্রেজেন্ট না, তাহলে অ্যাক্টিভ। So it is chronic active hepatitis B. কেন বলা হলো? Presence of HBS antigen in the blood for more than 6 months confirms chronic. Anti-HBC IgM negative but IgG is positive. তাহলে chronic infection. আর HBE antigen positive indicate viral replication. তাহলে এটা হলো শুধু ক্রনিক বললে হবে না, ক্রনিক অ্যাক্টিভ, কারণ HBEটা এখানে দেওয়া আছে। পরেরটা হলো HBs antigen present for more than 6 months. আর কিছু নেই, আর অ্যান্টি এইচবিসি আইজিজি প্রেজেন্ট। অ্যান্টি এইচবিই প্রেজেন্ট, তাহলে অ্যান্টি এইচবিই অ্যাবসেন্ট, এইচবিই অ্যান্টিজেন অ্যাবসেন্ট, বাট অ্যান্টি এইচবিই ইজ প্রেজেন্ট। অ্যান্টিজেন নেই কিন্তু অ্যান্টিবডি আছে, কেন? হ্যাঁ, ইলেকটিভ তো বলে না, ওটা হচ্ছে তোমার লো ইনফেক্টিভিটি ফেজ। ক্রনিক হেপাটাইটিস বি উইক লো ইনফেক্টিভিটি ফেজ। কেন বলা হলো? HBs positive for more than 6 months confirms chronic infection. HBe antigen negative and HBe positive indicates no viral replication or low infectivity. Anti-HBc IgG positive and IgM negative means past exposure. বুঝতে পারলো? Next, HBc IgM present, anti-HBe present and anti-HBs present. Immune না, এটা রিকভারি ফেজে আছে। অ্যাকিউট হেপাটাইটিস বি ইনফেকশন ইন দ্য রিকভারি ফেজ। ফার্স্টে হয়েছিল, এখন রিকভারিতে আছে। কেন বলা হলো? anti-HBs positive with anti-HBc IgM positive suggest early recovery phase of acute hepatitis B virus infection. আর HBe antigen negative with HBe positive suggest declining viral infection. আচ্ছা, এখানে শুধু IgM is present, কি হবে? এটা আমি বলেছিলাম, একটু আগেই বললাম, পড়ার সময় বললাম না, আমি ওই ফেজটার নাম বলিনি। একটা ফেজ হয় না, উইন্ডো ফেজ, অ্যাকিউট হেপাটাইটিস বি ইনফেকশন ইন উইন্ডো ফেজ। না, উইন্ডো পিরিয়ডে না শুধুমাত্র অ্যান্টি এইচবিসি আইজিএম পজিটিভ থাকবে, আর কিচ্ছু পাবে না উইন্ডো ফেজে, শুধুমাত্র ওটাই পাবে। ওটাকেই বুঝতে হবে যে হ্যাঁ উইন্ডো ফেজে আছে, বুঝলো? Only anti-HBc IgM is positive in the window period of hepatitis B virus. Only anti-HBc IgM will present. HBs antigen negative and anti-HBs negative surface antigen has disappeared and protective antibody not yet formed. এখনো ফর্ম করা শুরু করেনি। এই যে পিরিয়ডটা, এটা হচ্ছে উইন্ডো পিরিয়ড। আচ্ছা, এটা বলো, HBs antigen present, HBe antigen present, আর IgM present. Acute, active, very good. Acute, active hepatitis B infection with high infectivity phase. So HBs antigen positive means current HBV infection. Anti-HBc IgM positive, acute or recent infection. HBe antigen positive, active viral replication with high infectivity. Well, HBs antigen negative are anti-HBs positive, anti-HBe positive, are IgG positive, are HBV DNA undetectable. Resolving hepatitis B. কেন? HBs antigen negative means no current infection. Anti-HBs positive means protective immunity present. Anti-HBc IgG positive indicate past natural infection. HBe antigen negative and anti-HBe positive low replicative phase. HBV DNA undetectable, no active viral replication. এটা বলো, এখানে here only anti-HBs is positive. Vaccine. Immunity to hepatitis B due to vaccination or post-vaccination immunity. কেন বলা হচ্ছে HbS antigen নেগেটিভ, নো কারেন্ট ইনফেকশন, anti-HBC both IgM and IgG negative means no past natural infection, anti-HbS positive protective antibody present. Without any past natural infection, protective antibody present means it is vaccination. এটা হলো টোটাল বিলিরুবিন 4.9, এর মধ্যে আনকনজুগেটেড 4, conjugated 0.9, আর urobilinogen increase in urine, urobilinogen increase, appetite normal, AG ratio normal, albumin globulin ratio normal, or scarcobinin increased. Due to unconjugated condition, hemolytic jaundice, basically hemolytic jaundice. Reasons: unconjugated bilirubin is high, urobilinogen is high, SGOT, SGPT normal, bile salt, bile pigment absent. তাহলে এটা হচ্ছে hemolytic jaundice. এটা হলো total bilirubin 8.9, unconjugated 3.4, conjugated 5.5, almost same. আর SGPT, SGOT অনেকটা বেড়েছে কিন্তু ALP সেই তুলনায় সেরকম বাড়েনি। P-time normal, albumin globulin ratio normal, color, stool color pale, scarcobinin decreased, আর urine urobilinogen normal, color deep yellow. Color? Hepatocellular jaundice. কারণ both conjugated and unconjugated bilirubin increased, SGOT, SGPT increased, bile salt, bile pigment present, stool color pale. Actually in hepatocellular jaundice আমরা দুটো ফিচার্স পাই hepatocellular এ। টোটাল বিলিরুবিন 10, এর মধ্যে conjugated হচ্ছে 8.8, আর P-time prolonged ALP বেশ অনেকটা রাইজ করেছে, সেই তুলনায় SGPT, SGOT খুব একটা করেনি, বেড়েছে কিন্তু খুব বাড়েনি। আর স্টুল কালার প্লেন। কি হবে? Obstructive jaundice. Mainly conjugated bilirubin increased, bile salt, bile pigment present in urine, আর urobilinogen decreased, P-time prolonged, ALP marked rise. বুঝলো?